video in the two groups.
PPT.
The video will be shared to all the groups, virtual group particularly.
Yes, ma'am.
When it plays in your own mobile, you can go to. So you can start your presentation now.
Share more PPT. हाँ मैडम just
Ranjana madam.
हाँ just 1 minute मैडम.
Start your presentation.
हाँ,
The
thank you.
training group, they will enjoy it.
Yeah, madam.
Quite educated. So,
This empty na? Eta empty. Yes, madam. So my subject
You will
today, my
share your
topic is, madam, I have shared my screen. Can you please see it? Is it seen?
Yes, yes.
So today's my topic is examining
Yes,
the
quite
uterus,
visible.
specifically the cervix and the endometrium. The learning objectives at the end of the lecture, you will be able to recognize the typical ultrasound appearance of normal cervix and endometrium, and also know the abnormalities in the cervix and the endometrium. So the key points are, at the end of the talk, you will know how to differentiate between normal and abnormal appearances of the cervix and endometrium, so that we can refer a case to another second opinion if we are in any doubt, or if we think that it is a case of malignancy. See, this is the most important slide for transvaginal scanning, and this should be imprinted in our mind. In all transvaginal scanning, as madam had told in the last session, there are three things are very, very important. One is optimization. Second is how to see it properly, orientation. And third is systematic examination. Systematic examination we will study in the lower part of the PPT. The optimization was already told by our Dr. Hasmukh Lal sir very nicely in the nomology. That is how the depth is important, how the zoom is important. But orientation in TVS is quite different from the normal TAS or transabdominal orientation. See, this figure is very, very important. All the anterior structure, that is bladder is anterior. So all the anterior structure will be seen towards right side. All the posterior structure, see the rectum, anal canal is posterior. So they are seen towards the left side of the screen. The screen is the picture of the patient. It is opposite to the one who is sitting in front. That you have to remember, the screen is a picture of patient, how she is sleeping, and it is opposite to us. This is when we are doing the footprint anterior. So all the anterior structure towards right side, the posterior structure towards left side. Second is superior and inferior. See, all the cephalate structure or the superior structure, see, this is the fundus of the uterus. So it is lower. And cervix of the uterus, it is upper. So all the inferior structures are in the upper part. All the superior structures will be seen in the lower part. All means that organ, the superior part of the organ is seen towards lower part, and the inferior part of the organ will seen in the inferior part. This is what has to be imprinted in the mind. The right side has to be the anterior part, left side has to be the posterior part, all the superior parts will be in the lower part, and all the inferior like cervix is in the upper part. So this is most important. In the this is the level where we are starting our transvaginal scanning, means at the level of introitus. The level of introitus is also very important in cases of unmarried females, because in unmarried females we are not able to do the transvaginal probing entering into the vagina. In the introitus, we can easily see this is the urethra leading into the urinary bladder. This is the vaginal canal, anterior vagina, posterior vagina leading into the endocervical. Then it will come into the uterus will come here. This is the anal canal leading into the rectum. So anything important any Gartner cyst or any rectovaginal nodule or bladder nodules, we can see in this part. Whenever we enter, we should not miss any type of pathology by seeing this. So this is the video I had already shown. This is the vagina. This is anterior wall of vagina. This is posterior vaginal wall. This is urethra leading into the urinary bladder. See, anterior. This is rectum leading into the anal canal leading into the posterior. See, this is left. And this is the uterus with the endometrium. So whenever we do enter into the vagina, we can find out some Gartner cysts. They are the anechoic structures. We can find out even tampons. Tampons are like elongated structures and they will cast lot of shadow from it. We can see some rectos. See, these are the nodules, endometriotic nodules, this type of hypoechoic nodules. I will also tell what are hypoechoic, anechoic and hyperechoic. These are the hypoechoic patches, but we can see if it is seen anteriorly, then we think about bladder endometriosis. And if we see posteriorly, then it may be something rectal endometriosis. But as this is our basic training, so this about teaching about this will be quite difficult. First, we should start the simple things. So now my first topic is cervix. See, the cervix starts from, this is the internal os and this is the external os. Whenever I am putting my probe inside, the first part, most adherent to the probe is anterior lip, anterior and upper lip. And this is the posterior lip. So see, this is the POD. This one is the POD with slight amount of fluid in it. So my part at present is internal os, external os, one part, lower part, cervical canal. So there are some cervical findings which have to be told in this slide. This is the cervical mucus. See, this is cervix. This is the cervix. This is uterus. This is the cervix, and we are seeing a slight small amount of anechoic structure. This is cervical mucus, and for reproductive medicine, this is very important because cervical mucus, seeing cervical mucus in the periovulatory phase, that is on day 13th or 14th, we can find out whether HCG injection should be given or not. This is chronic cervicitis. See, we are seeing some chronic echogenic spots. This is the cervix, this is the endometrium. This is one is the endometrium. So we are seeing some echogenic spots over here. If there is lot of infection, then we can even see some fluid released from it. Now, the important physiological finding is Nabothian follicle or cyst, which we are seeing in many of the cases. They are the mucus-filled cyst on the surface of the cervix caused by, see, we know this is external cervix and this one is the portiovaginalis, which ectocervix, which is lined by squamous epithelium, and this is the endocervix, which is lined by the columnar epithelium. When the squamous epithelium grows and covers the columnar epithelium of the endocervix, that time the tissue growth can block the cervical glands, and then they are seen as Nabothian cyst. See, these are the anechoic structures, anechoic. Why I am telling it anechoic? Because all the sound waves are passing through it. It looks black in color. All sound waves pass through it, and on putting Doppler, and they are also avascular. See, you can see all these cysts. They are anechoic and avascular. When I am putting Doppler over it, no Doppler's flow will be passing through it. Now comes to cervical polyp. Cervical polyps are sessile or pedunculated, well circumscribed masses within the endocervical canal. See, these may be hypoechoic, they may be hyperechoic. Identifying the stalk. The stalk means the part of the polyp which is attached to the endometrial or endocervical area. So identifying the stalk of the polyp will show whether it is endocervical or endometrial. We can find out the stalk of the ear properly by seeing on Doppler, there will be a feeding vessel through it. Now comes cervical cancer, which is very, very important. It's a heterogeneous mass. See, the masses are like this. It's a heterogeneous mass, and it will show very increased vascularity due to neovascularization. All vessels get enlarged. All vessel, there is color splashes over it. But I will tell that in during my endometrial cancer slides. So in the although cervical cancer is normally seen high risk or lower risk by 3D and MRI, but even in gray scale also we can find out some cases, like if the size is 4 centimeter or less than 4 centimeter or more than 4 centimeter. We can even see parametrial invasion. The tumor may be invaded into the vagina, into the adjacent organs like urinary bladder or rectum. And if in cases of staging more than 3B, we can also find by transabdominal scan hydronephrosis of kidneys. There may be para-aortic lymphadenopathy, there may be pelvic lymphadenopathy, or there even may be metastasis in the liver. So now my second topic is endometrium. Endometrium is a very dynamic structure. See, you are seeing the whole uterus. This is a cervix. This is a Nabatean follicle over here. And from here, the bottleneck appearance of the endometrium, this way is the cervical canal and this way is the endometrium. See, you are seeing the endometrium in such a nice manner. This whole is the endometrium. And today, at present, we will study only this endometrial structure. So there is a lot of difference between the endometrium of reproductive stage and endometrium of the postmenopausal ladies, because the endometrium undergoes through the menstrual cycle or cyclical changes under the influence of estradiol and progesterone, our hormones. So this is the endometrial changes, but I would like to show the next slide in which we can see the change between endometrium and the ovaries. This is a slide. All 4 slides are taken from the same patient under different menstrual cycle period. So the first one is shortly after menstruation. See, small follicles. The functional layer of the endometrium has been shed. So now only very small, this only pencil-like endometrium you can see. One thing more is the endometrium is made up of 2 layers. One is basal layer, another one is the functional layer. When we are having menstruation, the functional layer gets shed off. So the only basal layer remains. So this is the basal layer, which constitutes only 2 to 3 millimeters. So this will be only 2 to 4 millimeter. If this is 2 millimeter, this is 2 millimeter, then it will be 4 millimeter thickness. This is shortly after menstruation. Then comes proliferative phase, that is 3 days before ovulation. See, the follicle has enlarged so much. It has become a dominant follicle at present and has started secreting estradiol. Under the estradiol influence, we have started increasing the functional layer, the basal layer remaining constant. See, this is the basal layer which always remains constant in thickness. It is this functional layer which is shred off and which again then regenerates and starts giving the appearance of endometrium of the proliferative phase. Coming to the third figure, that is a proliferative phase just 1 day before ovulation. This is also very, very important, like cervical mucus. This is an important slide for reproductive medicine, the clinics and nursing homes and the medical colleges, in which we are seeing the dominant follicle. If we do the Doppler, then lot of vascularity will be seen around it. And because of this estradiol secretion, we are seeing a trilaminar appearance of the endometrium. See, this is the endometrial canal lined by mucosa. Very, very important. This is endometrial canal lined by mucosa. This is the hypoechoic layer, the functional layer. Remember, this is the functional layer. And this one is the hyperechoic basal layer. So we are having trilaminar appearance. This one is mucosa, the endometrial cavity mucosa. This is the functional layer, and this is the basal layer, trilaminar appearance. As soon as we go into the secretory phase, 6 days after means ovulation, our on this, I think, is it seen properly or not? This thing is getting, I think, are you able to see this?
Yes, we can
Yeah,
see.
yeah, we could see it.
Everybody is able to appreciate.
Yes, yes. Now I can show you. So just after ovulation, see, this dominant follicle has become a corpus luteum. We are having some internal echoes within it that I will be taking up in the next session. And the endometrium. This was the endometrium. Now the endometrium has become homogeneous and hyperechoic. This was a hypoechoic layer. This was a hypoechoic layer. Only basal was the hyperechoic. But now it has become a hyperechoic layer because all the glands in this phase, the glands were becoming tortuous and the vessels were becoming very, very tortuous. Glands were becoming straight. It was secreting this secretion of the mucin and the glycogen. It makes the
Knowledge
lining
of Douglas
hyper.
obliteration can be predicted using dynamic transvaginal ultrasound sliding sign technology.
So this is the hyperechoic. This also shows ring sign because the increased density starts increasing from basal layer. So see, there is a line, thin ring-like structure. This is a ring-like structure, which is also seen in cases of secretory area. This also, see, over here, there was no enhancement behind the posterior part of the endometrium. But over here, you are seeing enhancement behind the posterior part. This is because of the tortuous vessels. The tortuous vessels are causing enhancement around the posterior to the endometrium. So we should know this is single line, pencil line. This is slightly 3-line structure, but this shows just trilaminar view of the endometrium. And this is homogeneous and echogenic, homogeneous and echogenic endometrium. So how to measure endometrial thickness? Very, very important. Each one of...
Vandana here. Hello, Vandana?
Yes, madam. So
Right.
how
Go
to
ahead.
measure endometrial thickness? Very, very important because each and every patient of gynec pathology, we have to do TVS and we have to measure the endometrium.
Let's show that.
Madam, I'm not able to hear what you're asking, madam.
No, it is disturbance. You go ahead.
No, no, it's okay. Okay, go ahead. Go ahead.
So how to measure
Go
the
ahead, go ahead.
endometrial thickness? Thank you, madam. So whenever we take endometrial thickness, the slide, the probe has to be in the mid sagittal plane, first thing. Second thing, we have to take the widest part of the endometrium. Third thing, we have to see the endometrium from the fundus till the cervix. All things have to be seen. Fourth is the endometrial thickness has to be taken perpendicular to the plane of sagittal view. Fifth and most important thing is this subendometrial halo should never be included in the endometrial thickness. This subendometrial halo should never be included because the subendometrial halo is a part of myometrium. It is not a part of endometrium. So these 5 things are very important. First is mid-sagittal view. Second is widest part. Third is the plane has to be perpendicular to the sagittal view. Whole of the endometrium we have to visualize from fundus to the cervix, and subendometrial halo should never be included in the endometrial thickness. Now, how to measure if there is some fluid? How to measure the endometrial thickness? When intracavitary fluid is present, we will measure the thickness separately, anterior layer, posterior layer, sum it up, and then give the endometrial thickness. So many times we are having endometrial pathology. If the endometrial pathology is endometrial in nature, we will include it within the thickness. But if the any endocavitary lesion is myometrial in pathology, we will exclude it. So any myoma, submucous myoma, myomatous polyp should never be included in the endometrial thickness, but endometrial polyp can be included in the endometrial thickness. So this is again same way, average endometrial measurements throughout, it is a dynamic structure. So we are having throughout changes in the menstrual cycle. In the menstrual phase, it is 2 to 4 millimeter. Proliferative phase, it is 4 to 8 millimeter. Another just towards 1 day proliferative ovulation, it is 4 to 8 millimeter, and secretory phase, it is 7 to 14 millimeter. Normally, we should remember the endometrial thickness increases 0.5 millimeter in the proliferative phase and 0.1 millimeter in the secretory phase. So this is another video in which again we are showing the endometrial, how the endometrial thickness is done in the video. So now the endometrium in the postmenopausal women. See, post all the things, it is under influence of estradiol and progesterone. As we know, the estradiol progesterone decreases a lot in cases of postmenopausal women. So the endometrium, only the basal layer, see, it's very, very thin, only the basal layer. But in the media, if the length, thickness is more than 5, but in some studies, they also show it is 4. So cutoff level of 4 or 5 should be taken in order to say about the postmenopausal thickness. One thing we have to remember, these days, lot of females are having HRT, that is hormone replacement therapy. In those cases also, the endometrial thickness will increase. But even then, they give a cutoff of 6 millimeter. In some ladies of breast cancer who are on tamoxifen therapy, the endometrium is too hypertrophied, and then it is having some cystic structures also. But never think it to be a case of endometrial cancer, because that is mostly confined in the basal myometrial layer. That is also very important. So ET 5 millimeter or 4 millimeter has to be taken into consideration. This is also how to see the endometrial thickening, but this video I'm not able to, I have already given the video before. Now, we have to describe the endometrium. I'll just tell something later. IETA, according to IETA, I will show how the endometrium is described. See, this is hypoechoic. Now, what do you mean by hypoechoic? Anechoic is the one which is totally black in color. All the sound waves passes through it. Hypoechoic is the one which is slightly lesser. See, this is slightly lesser. This is anechoic, this black. See, I'm showing this black is anechoic. This is slightly lower. So it is hypoechoic. Some of the sound waves are passing and some are reflected. This is iso. Always the echogenicity of the endometrium has to be taken in comparison with the myometrium. See, this is myometrium. So in comparison to myometrium, this is hypoechoic. In comparison to myometrium, this is isoechoic, means similar to myometrium. And this in this secretory phase, in comparison to myometrium, this has become hyperechoic. So hyperechoic means lot of sound waves are reflected back. In this, they are not so much reflected. In this, they are not reflected. And in this, all are passing off, no reflection occurs. So the first point was how to do thickness. Second point was how to do echogenicity. Now our third point is endometrial myometrial junction. So endometrium, this is the endometrium, this is the myometrium. See, I should show in this figure. This hole is the endometrium and this is the myometrium. The endometrial, see, this junction is proper, well defined, and we are not having any interruption. So this is known as regular endometrial myometrial junction. In this case, see, we are seeing something irregular. Maybe it's a case of endometrial cancer. See, this is so irregular. So this is case of, this is one is also irregular. So this is irregular endometrial myometrial junction. It may be because of CA, cancer. Another one is interrupted. See, this is the interrupted. This is interrupted. In case of myomatous polyp, when the myomatous or submucous myoma, the myoma has been entered into the endometrial cavity. Therefore, the endometrial junction is disrupted or interrupted, but it is not irregular. So now comes IETA. IETA means International Endometrial Tumor Analysis. Like IOTA, the International Ovarian Tumor Analysis, in 2008 in Chicago, the World Gynecologist Group found out this IETA, so that all the reports of gynecologists from one end of the earth world to another end, they will describe all the terminology in a common way, so that the area, if I say endometrial echogenicity hypoechoic, the one in America should also say the same. Therefore, IETA consensus has given a statement in which we will describe endometrial echogenicity as I described this way: hypoechogenic, isoechogenic, and hyperechoic. They should describe endometrial midline. Endometrial midline, I will show in this. See, this is endometrial midline. Endometrial midline is either regular or interrupted. Interrupted when there is some polyp or some SOL within the endometrial cavity, then it gets interrupted. So and this is the midline. Always remember, this is the midline. This whole is the echogenicity, and this is the endometrial myometrial junction. Now, if there is fluid in the cavity, we have to show the fluid. That also I will just, in the next slide, I will see. Endometrial lining has to be seen. Now comes to intracavitary lesion. Intracavitary lesion may be either peduncle. This is the peduncle. This is whole is the cavity. This white color is the endometrium, and this is the pedunculated SOL. This is a sessile SOL. Now, how can, and this both pedunculated also sessile. Now, how I will say that it is pedunculated or sessile? I will take the diameter of the base, this diameter, divided by this diameter, the maximum transverse diameter of the lesion. If it is less than 1, means it is having some stop. So this is pedunculated. If the base divided by this is more than 1, then it is a sessile. In this way, we should find out the pedunculated or sessile intracavitary lesion. And how to describe the intracavitary lesion? So first we have to take the measurement. As we see in all cases, it is 3 orthogonal planes: sagittal means longitudinal, anteroposterior, and then width. All the endometrial lesions are arising, lesion should be shown, as well as those which are arising from the myometrium. Now, it's a subjective assessment to tell the lesion to be localized or extended. If it is less than 25%, see, this is less than 25%. But we are not calculating in this, we are not calculating, it is a subjective assessment. If it is less than 25% of the endometrial surface, then it is localized. If it is extended, then it is written as extended. Echogenicity of the lesion has to be told, outline of the lesion has to be written, and then color Doppler, that I will show in the later slide. Now, degree of the protrusion. This also we will study in the myometrial slide. The proportion of a myoma protruding into the uterine cavity at sonohysterography when there is pre-existing fluid in the uterine cavity over here. But this we can see even in the ultrasound TVS. See, this hole is inside the endometrial cavity. So it is grade 0, 100%. If it is lesser, greater than 50% inside the endometrial cavity, it is known as grade 1. And if it is less than 50% inside the endometrial cavity, see, this is less than 50% inside the endometrial cavity, then it is told as grade 2. But this is a myometer slide. This is again another myometer slide in which we are showing how to measure the intracavitary lesion. This lesion we are seeing, and this is the longitudinal, this is the anteroposterior, and this is the width. So now we will come to some common endometrial pathology. Endometritis. Normally, endometritis doesn't occur in the ladies because we are having every month we are having menstruation. So the mostly the inflammation, infection doesn't occur, but still sometimes after doing DNC, DNA, or so many times after some operations, we get endometritis, and which can be seen as irregular endometrium. In these cases, sometimes we also see endocavitary fluid. Sometimes we also see gas because of the gas producing organisms causing endometritis. Now come to the endometrial polyp. The endometrial polyps are those which are arising from anywhere endometrium. Endometrial polyps are having bright edges. See, this is the bright edge of endometrial polyp. Why there is bright edge? Because this thing is the endometrial cavity. This is the interface between this and this. Otherwise, this is bacillus. So this is, we have to find out a thin layer that I will show by sliding sign. Just when we slide between the vagina with the probe, to and fro movement, or anterior and posterior we are moving, then we can see this small cavity, and then we can find out, yes, this is a polyp. Secondly, it is hyperechoic. See, the it is so much hyperechoic than the myometrium. It is hyperechoic in nature. There are some regular cysts within it. See, this is the cyst, and this is the interface, and this is the cyst. On putting a Doppler, I'll see a single feeding vessel. But so many times we also see myomatous polyp. So how to differentiate between myomatous polyp and endometrial polyp? See, this is endometrial polyp and this is myometrial polyp. Endometrial polyps are hyperechoic, myometrial polyps are hypoechoic because they are in conjunction with the myometrium. Secondly, see, the endometrial polyps are having acute origin from the base. These are obtuse origins. There is an equal sign. The whole endometrium lining is covering the polyp, myomatous polyp. But over here, only a single line because this is arising from endometrium only a single line. On putting Doppler, we will have a single feeding vessel over here. But in case of myomatous polyp, we will see peripheral or circumscribed vascularity. So see, there is a single feeding vessel entering into the polyp. This is a video, I'm not able to show, but this video, if I do a sliding movement, this endometrial cavity, I can see separate from the polyp. This will show, this is sliding sign. This will show that this is a case of polyp and not any endometrial origin, endometrial carcinoma or something like that. So typical ultrasound features of submucous myoma, they are solid tumors. We will see in the next class. The echogenicity is same as myometrium, and we will have all circumferential ring of color around it. Now, if there is intracavitary fluid, what we will write in our report? We have to measure in all the three parameter perpendicular manners. First is sagittal view. I can take the length. I can take the anterior-posterior. Then I have to make it transverse and I will take the width. But the amount of intracavitary fluid is always defined by the largest measurement in the sagittal plane. The largest measurement in the sagittal plane has to be written properly. Secondly, the intracavitary fluid has to be shown. The previous IETA, we had read how the intracavitary fluid is looking. So it may be anechoic if there is no echo within it. It may be ground glass if there is slight fine internal echoes within it, or it may be mixed echogenicity as occur in the RPOC or molar pregnancy. Now comes RPOC. This is very, very common. We have not many cases of RPOC. Daily we have to do ultrasound in the hospitals and all. So in the B mode, you can see echogenic matter within the endometrial cavity. See, this is the cervix and this is the endometrial cavity. So we are seeing echogenic, mixed echogenicity. See, this is some anechoic structure is also there, some hyperechoic structure also there, some hypoechoic structure also there. So endometrial contents are of mixed echogenicity, and when we are putting vascularity, lot of prominent vascularization within the uterine cavity confirms the diagnosis of retained product of conception and differentiating it from blood clots. Because see, this was a case, the patient had come just 12 days or 15 days after the delivery, and she was having lot of bleeding. We saw it a case of postpartum uterus. See, such a big uterus, postpartum uterus. In the endometrial cavity, there were ecogenic particles. But when we put the Doppler, we are seeing no blood flow within the ecogenic content. So this represents blood clots without retained products. So we don't have to do anything. We will wait for some time and conservative therapy, not DNE. Now, this is a case of arteriovenous malformation. This we will take it in the myometrium chapter. But you see, the arteriovenous malformation, they are the direct arteriovenous circulation without any capillaries in between. So lot of splashes of the vessel over here, vascular supply, you see, lot of supply. Only important thing is, in case of AVM, we should not do any DNC, because the curettage of this area will give so much of bleeding that patient may succumb also. So we should have a conservative therapy for 4 to 6 months, and then it disappears. Now comes molar pregnancy. Molar pregnancy is, see, this, the placenta becomes snowstorm appearance. Snowstorm appearance with cystic and hyperechoic and somewhere hypoechoic structures are totally surrounding in the endometrial cavity. But the molar pregnancy is due to abnormality of the trophoblastic tissue, and the trophoblastic tissue may appear in twin pregnancies separately. So we had seen a case of, even in our PRM, this DHH Baripada also, I think Sukanti madam must be listening to me. We had a case of twin pregnancy in which one placenta was normal. See, this placenta is normal along with a normal child, fetus. And another placenta of the twin pregnancy was having molar tissue. And so we had each and every time, whenever that patient used to come, we used to only counsel her that she should be showing, she should have some her delivery in the higher setups, so that if something happens, we can do in these tertiary centers only. This is a case of, so snowstorm appearance is the pathognomonic of hydatidiform mole or molar pregnancy. This is invasive mole, but invasive mole is also not in the basic chapter. Still, I am showing the whole uterus is endometrial cavity is covered by this snowstorm appearance, and on vascularity, lot of vascular supply is seen within it. So this is lacunar type of arteriovenous supply. So now let me tell about endometrial cancer, which is very, very common gynecological cancers. In this, we are having thick endometrium, irregular endometrium, inhomogeneous echogenicity. As we know, all cancers means lot of vascularization, neovascularization. So see, so much of vascularity is there within the endometrial tissue. Over here, we are seeing thickened inhomogeneous myometrium with multiple small cystic areas. These are the cystic areas. It is complex mass consisting of, see, what do you mean by complex? Consisting of anechoic structure, hypoechoic structure, and hyperechoic structure. See, in this case, the endometrium is undergoing cancer along with pyometra, or hematometra. That we can tell only by the MRI and all. In ultrasound, we can only say if there is a fluid-filled cavity within it. Now comes color Doppler. In all organs, we have to read about color Doppler and the power Dopplers also. So ensure the color power Doppler includes myometrium as well as the surrounding myometrium. The magnification and settings are adjusted to ensure maximal sensitivity for the blood flow, and are the ultrasound frequency. Always remember, ultrasound frequency of curvilinear is 3 to 5, of 3 to 4.5. In case of transvaginal probe, it is 6 to 7.5. So we are having very, very good frequency. The PRF has to be 0.3 to 0.6 kilohertz. As the vascular supply in the case of reproductive organs like uterus is having low velocity, high resistance, low velocity. So if we put PRF at 1 or more than 1, we will not see any blood supply within it. So PRF has to be maintained between 0.3 to 0.6 kilohertz. The wall filter will be 30 to 50 hertz. So the color power Doppler gain should be reduced until all the color artifacts disappear. And the color score, as we know, is a subjective assessment. So see, in this case, the IETA or International Endometrial Tumor Analysis Consensus Statement states the color score as color score of the ovarian pathologies. So color score 1 means no color. Color score 2 means minimal color. Color score 3 means moderate color. And color score 4 is abundant color. But always think seriously that PRF has to be maintained between 0.3 to 0.6 kilohertz. That is 3 to 6 centimeter per second velocity scale. Now Madam, I am audible. Hello.
Yes, yes, you
Yes,
are audible.
yes, audible.
Thank you, sir.
Yes, you're quite audible.
Thank you.
Questions going very well. We can understand.
Thank you, madam. Only a bit more. Thank you, madam. So now I'll tell something about benefits of fluid instillation, that is SIS, saline infusion sonography. In case of saline infusion sonography, this is the cervical canal. So I will put a catheter within the cervical canal over here. You can put Foley's catheter also. Then I will put, just enlarge the balloon. Just you can enlarge by 3 to 5 millimeter of saline so that it will stay over here. Now I will infuse 5 to 30 ml of saline, sterile saline within the endometrial cavity. This should be undertaken when the endometrial pathology we are getting confused, whether it is something important or something endohyperplasia or something polyp or myomatous polyp and all. In that case, we should do it. We should do it in proliferative phase, because in the secretory phase, we should always think maybe it is a case of pregnancy. So the balloon will be over here and the saline will be infused here. So see, we are seeing so nice polyps. Over here, we are seeing sessile polyp like this. Over here, we are seeing pedunculated polyp like this. And over here also another polyp. Now, another point is intrauterine adhesions or Asherman's syndrome. In Asherman's syndrome, the patient starts having amenorrhea. This occurs mostly after operative surgeries like DNC, DNE or myomatous myomectomy also. See, we are seeing echogenic bands. They are doing breaking in the, see, normal we have the endometrial lining. So they are breaking the, this endometrial lining is, hypoechoic lining is broken, and now the echogenic spots we are able to see. If the echogenic bands are seen, then we should think of the Asherman syndrome if the patient is having amenorrhea. Another slide is this. This is the skip lesion. Over here, we are having functional endometrium. In this band, this is the whole is the skip lesion. Over here also, we are having lot of skip lesions, but still there is partial obliteration of the endometrial cavity. So slight amount of fluid, menstruation is occurring. This is a total obliteration of the endometrial cavity. The patient is not able to have, menstruation in this case. Now coming to very, very important, these are the pathologies, but still so many times we also have to do ultrasound in order to find out the position of IUCD. See, this is when the patient comes. Now, see, these days we are giving lot of PP-IUCD and PA-IUCDs in our hospital to all the patients, and the patients interval IUCD we are having thread down. But in PPICD and PAIUCD, sometimes the thread gets rolled up. And then in the missed thread, they refer the cases for ultrasonography and also for X-ray. But in ultrasonography, we can easily find out the position of endometrium if it is within the endometrial cavity or within the endometrium and cervix. See, this position is so good position. The endometrium is lying. This is the endometrial cavity near the fundus. Our IUCD is just near the fundus. So nice placement. This hole is IUCD. Normally IUCD length is 36 millimeter and the width is 32 millimeter. See, we are seeing such a nice 36 millimeter property. This is the sagittal view. On doing transverse, how will we do transverse? I had told before, the sagittal view is when the marker is facing 12 o'clock position. And transverse is when I put the marker towards 9 o'clock position. So always remember how to do sagittal and transverse. So when I put transverse, my property is just one spot is seen along with the shadow. This is a case of hormonal IUCD. In hormonal IUCD, the manufacturer put echogenicity only in one of the area. So this is the area and just near the fundus. So this is my correct position. In hormonal IUCD, we localize the IUCD by the shadow of the shaft. This is the shadow. This hole is the shadow of the shaft, stem. Shadow of the stem of the hormonal IUCD. On doing transverse, see, I am seeing this is the shadow. This is the longitudinal and this is the transverse. I am seeing the shadow of the hormonal IUCD. But the correct placement is normally seen in 3D. See, so nicely we are seeing the IUCD in the 3D pictures. Now see some of the incorrect positions of IUCD. See, the upper point of the IUCD is in the isthmic region going into the cervical cavity. And my fundic region is over here. So this is too low. In this case also, see the fundus is over here and this is also too low a position. This is just one. In another case, I am having the IUCD totally in the cervix. This was a case of PP IUCD given just after, and the patient came 8 months after cesarean. And see, this is the cervix, this is the uterus, and my IUCD, lower part of IUCD is towards the uterine scar. Now, in incorrect position of IUCD, one very important thing is the distance between the endometrium and the IUCD should not be more than 5 millimeter. The distance the distance between the endometrium and the IUCD should not be more than 5 millimeter. Second is the distance between fundus and the upper part of the IUCD should not be more than 2 centimeter, as this is 2 centimeter myometrial thickness. So remember, this should not be more than 2 centimeter. This should not be more than 5 millimeter. Now comes the hydrometrocolpus. So many times a female comes with cyclical pain and not having any menstruation. At that time, when we see transabdominally, you can also see translabial. But when we see abdominally, we see the vagina is, the cervix is also filled, vagina also a bit of shape, and then this is cervix, this is endometrium. So we are seeing uterus fluid in the uterus, in the cervix, and the this may be because of imperforate anus, imperforate hymen, or vaginal atresia. More common, more seen properly by MRI. But in ultrasound also, we can see the length of the vagina. That will show the vaginal atresia or imperforate hymen. This is a case of subseptate uterus. See, in grayscale, this will be, again, it will be confirmed by 3D. But in grayscale images, we can, on doing transfers, we can see a broad fundus. See, fundus is so broad. We are
There is
seeing
there is
two
lot of
cavities.
background noise. I would request everybody to mute themselves because there is lot of background noise and we are not able to listen to Dr. Anjana's talk. Please mute.
ये second वाला है, first वाला नहीं है क्या? ये first वाला हम लोग कर चुके
So, sir, last 2 or 3 slides, sir.
हैं। नहीं किया। तुम करो।
Sir, I'll continue.
Yeah, I think you can continue.
इसमें कमी
So the subseptate or any congenital anomalies of uterus can be found by
नहीं वो पीछे दो पेज में होगा ना पहले।
ray scale images of broad.
ये सारे
On transverse image, we will have a broad fundus.
इसमें कम
In secretory phase, you can see 2 endometrial cavities. Now, how will I say that it is 2 endometrial cavities? On putting Doppler, I will see that there is myometrial Doppler flow within this area. So this shows that the 2 cavities are 2 separate endometrial cavities. They are due to Mullerian agenesis in the fundal part. So my key points are, we should use a standardized terminology of IETA whenever we describe any ultrasound images of endocavitary or endometrium. The IETA pathology is very, very important. It should be taken into consideration. Which patient should I refer? All those cases in whom we are uncertain about diagnosis, especially the cases of malignancy, or any doubtful case, we should refer to the higher center. And whenever we are in doubt, we can refer the case for second opinion also. Thanks a lot. I think I am able to tell something about endometrium and cervix.
Yeah. Your talk was very, very clear and very vivid.
Very
Yes.
clear, illustrative.
Thank you, sir.
It talks about all the experience that you have had practically and you have nicely explained. Very practical tips you have given all. Just one.
Thank you, madam.
When you show the echogenic endometrium during the secretory phase, there is actually a post enhancement. Proliferative secretory phase because vacuoles are small and they reflect sound waves amongst each other, just like in a molar pregnancy. That is why they appear echogenic. And since they're fluid filled, they're always followed by a posterior enhancement because sound waves, although it is echogenic, sound waves travel better through a secretory endometrium. Actually, when you
This
are
secretory endometrium, this posterior enhancement.
so that posterior enhancement and explain why to all why that posterior enhancement occurs, and it is very much diagnostic of a secretory endometrium. Yes, it's an excellent presentation. So, isn't this posterior enhancement? Posterior enhancement should have been explained by in the first session itself. The different it was, I think, posterior enhancement occurs when sound wave is passing through a fluid medium. That's why cysts are diagnosed by posterior enhancement, and posterior shadowing is when the sound waves cannot pass and there is side lobe artifact. Been discussed, I think, in the first. What is side lobe artifact? What is posterior enhancement? What are the different types of artifacts? Grating artifact. Commental artifact. Yes, there's a question in the chat box. Ranjana, please answer.
Yeah. Madam, secretory endometrium. Madam, secretory endometrium.
No, there's a chat box, ma'am. Can you please repeat this? No. See the chat box. See the chat box.
Madam,
Madam, question about copper tea, madam.
Yeah, it is a
Please,
question
last
about.
please tell the
Mona Lisa
question.
Pal has asked.
Copper tea.
Can you
Copper
please repeat the distance 5 mm, 5 cm, right? 5 cm.
No, sir. It is, sir, we are having, sir, this, I'm just showing copper tea, no? So I'll
Copper
just
tea,
say,
distance-
yeah.
Somebody
the
misunderstood.
distance-
Madam, tell,
from-
tell again copper tea, about copper tea.
Copper tea. see property. I'll just show and then it will be very easy. See, this is the distance of upper part. The property upper part should always remain in the fundic part of the endometrial cavity. This is middle part, this is lower part, this is cervical canal. This length, if we are not seeing the uterus, this thing, so this one should be at least only 2 centimeter. It should be less than 2 centimeter. So 2 centimeter shows that the myometrial thickness is normally 2 centimeter. First. Second point is this distance between the endometrium and the upper part of the property. It should not be more than 5 millimeter. 5 millimeter. Because see, after that I will show you the lower position. So this is how much centimeter? Lot many centimeter. 5 to 6 centimeter above. See how much? So much above. You have more than 5 millimeter. This shows it is more than 5 millimeter of the distance between the one part and the endometrium. So they say if it is more than 5 millimeter or if it is more than 2 centimeter, because 2 centimeter is the myometrial length. See, anterior we are having 2 centimeter, 2. Therefore, our whole length of myometrium, total length is about, means anterior-posterior diameter of the uterus is about 4 to 5 centimeter, because it is about 2 plus 2 or 2.5 plus 2.5. So this should be more, not more than 2 centimeter. It's written in the book. And this distance between outer part of property and the endometrial canal should not, endometrium should not be more than 5 millimeter. 2 centimeter, 5 millimeter.
Ranjana madam, have you seen any cases of property perforating? You know,
Sir, I am telling,
myometrium?
sir, I am telling you one. One of our cases we were doing in the evening. I was alone, and it was a case of ruptured ectopic pregnancy. I did it was right side ectopic pregnancy ruptured, but then I saw a lot of adhesion here and there. What to do? I called another one, Dr. Nanda. He is assistant professor over here in PRM. I called him. While doing the surgery, we found a property in the sigmoid colon. How to take it out? We had called the surgery people also, but they came so late, and then by that time we had already taken out the property, and it was very, it must have taken at least 1.5 hours for the ectopic pregnancy patient to be completed. And we found the property in the sigmoid colon.
Right. And sometimes what happens is when I have seen cases where property is not present in its normal position, and one of the shaft, in the transverse one, has gone into the myometrium, and this woman was always complaining pelvic pain. So her symptom was pain, and on examination, the property had perforated when it had gone outside the endometrium, and had one of the shaft was present in the myometrial region. Right.
Yes.
So this also happens. So
I had also seen one when in the cornu of the uterus, the property had perforated and it was extruded.
Right.
The machine had detected, and laparoscopically when we saw momentum was adherent to the cornu, we just dissected it out and removed that displaced IUCD laparoscopically. So though that's why I always tell all gynecologists should learn ultrasound. Both
Pramodini madam, any experience you have? Pramodini madam?
No, sir. No, sir.
No? Okay. Do you do a lot of gynae scan?
I kept this picture for the postgraduate examination plate. I don't know if they've still kept it or not. Please don't leave. We'll launch the poll questions, and then each of the questions will be discussed by Dr. Hasmukh Lal. Please don't leave.
Sambit babu achanti line re? Sambit babu achanti?
Chat box.
Sambit babu? Okay, I have shared IETA terms and conditions, I have emailed it to Sambit Babu, Dr. Sambit Jaina, and hope he will post it into our group so that our participants will be able to see that. Ranjana madam, can you take your share screen off?
Share screen off. हाँ sir, just sir, please make me a part of that group. I am not included in that group.
In the virtual group, you are there or not there?
No, that group, sir, I am not there.
Okay.
Last
okay,
time also I had requested you.
Okay. Thank
Thank
you.
Thank you, sir. Thank you, ma'am. Thank you, sir. Thank you, all my colleagues.
Thank you. It was a
Thank you.
wonderful presentation.
Thanks a lot,
No,
madam. You
and
all
now
have
Hasmukh
helped
sir
me.
wants
Even
to-
Hasmukh class sir has helped a lot, madam. Hasmukh sir has given lot of slides to me out of this.
Yes, yes.
But I have prepared a lot also,
He
madam.
does
I
not share
like,
with
madam,
me.
ultrasound is my passion. I like
But-
it a lot.
Your screen is not
Speaker
yet
gives
gone.
me a
Your
surprise.
screen is not yet gone. अपन का screen ta ask someone
Stop
to
sharing
help
for
you.
him. Ranjana,
बंद
stop
कर दो,
sharing.
बंद कर दो. हाँ, ना मतलब
Sharing.
sharing का बंद करो.
No, no, look at the stop share.
हाँ,
Stop
Yes.
share and click that.
stop share ये करो.
Stop share अच्छी.
ऐसा?
View option रे देखो तो
थोड़े
top
थोड़े
of the
थोड़े
top रे देखो view
टॉप
options.
रे से कौन टॉप रे अच्छी. Stop share. एटा stop share.
Yeah.
हाँ, thank you sir.
Okay, let me show you if I have some video of some normal slide. Let me try and show you. If it is possible, I will show you. Yeah. So
Post poll have been launched.
आ गया post poll टा करू था तो से माने
Post poll करो कहीं छाड़ के जाओ नहीं. Hello, because each of the questions will be discussed by Hasmukh sir, and in addition to that, he will give you some extra points also in his own screen. So please attempt the poll questions quickly. Don't leave till all the questions have been discussed. This is a very important. Last lap is the most important part of your learning. Very good. So 100% hela mane question 1 re. Don't leave. This is the most important part of your training.
this is a sliding sign. You can see that on giving pressure, the uterus and the posterior wall of the or the anterior wall of the rectal mucosa, they are moving
Sir,
against each other.
their answer is sir. Hasmukh sir, please. Hasmukh
Yeah.
sir,
हाँ,
otherwise
madam.
their attention will be distracted.
Very easy to answer all this after Dr. Ranjana's talk, which was very clear.
Sir,
So
even
clear.
this is easy because we are doing studying this in the
No,
gynecological
not
part.
for you. Not for you. It is for the listeners,
The listener
participants.
also, if they, it is only gynec.
Yeah.
We have to study, and then at the I ask all my participants to keep at least one case in the end for transvaginal, because the practice makes a person perfect. So each day, if you do one case, then you will surely try to attain the excellency in TBS imaging also. And TBS needs time. It's not like transabdominal. TBS needs some time and some privacy also. Always ask the patient to empty the bladder and then only start doing it. If it's a male gynecologist, one female attendant should be present with them. The light should be slightly off. Only a dim light should be there in the room.
Thank you, Ranjana madam.
Thank you, Sanjay. Sanjay is my classmate.
Oh,
And he was there with us in DHH Baripada. Just now, one and a half years back, he has gone to Capital Hospital. He was there
Yeah,
with us.
We have worked.
We work
very
together only.
Dr. Ranjana has 28 years of
Great
experience.
phonologist himself.
28 years of experience she has.
Sir, I like ultrasound a lot. I can't tell, sir. At the first, sir, when HK Monti sir had told me, I was dreaming ultrasound, I was eating ultrasound, I was sleeping ultrasound, sir. So much of a...
Yes, we noticed too. In Kishore, there Rajana madam will be sitting. When we didn't hold the transducer, we used to take patients to Kishore sir for a scan.
Kishore sir was doing in the evening and we were doing in the morning.
Then
HK Montis and myself in the morning in New Life. Thank you, Aravinda.
हसमुख सर कौन कहबे कहउतले सर
Again?
सर कौन कहबे कहउतले स्लाइड
I was to show
sir, କହିବେ.
normal side. Don't worry, I'll
କହିଲେ ସମସ୍ତେ ଶୁଣିପାରିବେ.
there is a lot of time, means I will put it later on. Yes. Now
କହିବେ ସମସ୍ତେ wait କର. People only otherwise the attention will be distracted. So everybody please attend the post polls quickly so that we can go to what Hasmukh sir has to say and then we'll analyze the results. Yes, 68% have answered. Quickly, all of you attend. Sorry, Yoshikro.
No, we are completed, madam.
Attention distract habo plus
संबित बाबू अछंती आपण संबित बाबू सुनंतु मु आपण को ईमेल करी छी
70% have
टर्म्स एंड कंडीशंस ऑफ आईईटीए टिके हम ग्रुप रे पकई देबे
आपण से सेटा भी जो ट्रेनर ग्रुप रे भी देछि
आज्ञा
ये ट्रेनर ग्रुप रे भी दे दियो
से ट्रेनर ग्रुप रे तबा को कहू छी
Thank you, Sangram.
Please don't go. There were 96 participants. Some have left. 16 of you have left.
Madam,
Unless
we have
it's an
so many
urgency, don't
cases
leave.
in DHH
You have some
and
issues in
yes,
your-
so that is why we have to go and all, madam. So many fellows must be in CSC and all. They must be having so many labor room duty and all. That's why it becomes difficult also.
There you are there. They can clarify the questions later on. Yes, it's a real problem.
Yeah,
But then
madam.
in spite of
Yesterday
that-
we had 9 cesarean cases. We started at about 5 o'clock. So it becomes difficult also.
I have one experience about you had said about hematocolpus, no? So either it is a trachea or a just the
Imperforate
hymen. Yeah, it is. How do I rule out? Do a translabial scan? You know, to do a translabial scan, you will know that okay, distance between your transducer and the fluid is very less in case of if it is a only unruptured hymen, intact hymen.
Yeah.
And in case of atresia, the distance is very high, the distance between the fluids. So
Increased.
this is one way to rule out. And if it is a, the one of the condition is very easy to treat. Just put a cross and all the blood is drained out if it is an intact hymen. So that almost becomes sometimes, in a minor OT, you can do that.
Sir, one more thing, sir, I had studied. In case of imperforate hymen, there will be distended blue color lining. But in case of vaginal atresia, there will be a dimple.
Yeah,
There will be a dimple in the translabial area. There will be a dimple which will lead into the vaginal atresia. So that is also one point.
One of
And
the
then
signs.
the length, one side. And then we can find out the length.
Right. So translabial is the easy way
It's
to
very
find
good.
it out.
Sir, so many times we are not able to do TVS. As example, in case of very large fibroids, large globally enlarged uterus.
Right.
There is a tumor in POD which is elevating the uterus above, or gross ascites also the uterus goes up. So many cases, and unmarried females we cannot do. So many cases we have to see the transabdominal view only.
Yeah, actually, in suitable cases, I'm not talking about unmarried woman, but otherwise also a complementary scan like abdominal and transvaginal have to be complementary to each other. That is the best way, because we have last time also, I think Dr. Pramodini discussed that if any pelvic pathology which is lying higher up will always be missed, because the transvaginal transducer is not penetrating to a great depth. So
not more than 10 centimeters. So anything which is goes above 10 centimeters, it's very difficult to do.
Lot of physics is involved. As you said, why we are seeing the uterus from cervix to the fundus. And again, the uterus you showed was in a horizontal level, so that the fundus and the cervix were on left and right side of the screen.
Right side of the screen.
So what happens? It is 90 degree. The perpendicular, the sound waves are hitting the endometrium beautifully at 90 degree angle. The fact that the continuity of the cervical mucosa and the endometrium tells us that you are exactly in the mid-sagittal plane. The two nice aspects you have demonstrated. And physics involved, I told you what was the physics, So many times I think we should not, I will tell you, when the uterus is sometimes lying axially, it is, vertically, you must have seen position of the uterus is vertical. So you will never see the endometrium very clear.
Yeah, we will not. Sir, even in midline, when it is not in a midline axial view, it's very, very difficult to find out the endometrium. Sir, it is also written, sir, it is also written that if you are not able to find endometrium, then we will write in the report poorly seen endometrium.
Or non-reportable, you can write is cannot be reported, it cannot be reported because of the position. So this is one thing, but slightly I have found my experience that if you are inserting the probe, try to tilt the uterus a little bit, try to push it somewhat. And sometimes, it gets a little straight, at least you can see that whether endometrium is visible or not. You cannot measure it, it will be wrong. It will be wrong. But point is, you can at least guess as to
endometrium. Correct.
Yeah. So you have to push it very hard a little bit and see if you can, because uterus is after all a free structure. If there is no adhesion, it will always move.
Sliding will be positive.
It will always move.
So another point is, when you are doing to and fro this, we will also find out tenderness, because in cases of endometritis and endometriosis, we will have probe tenderness also.
Site specific. You have to,
Site-specific tenderness.
you have to look whether the right adnexa is tender
Is
or
tender
the
or
left
not.
adnexal region is
Is
tender.
yeah.
You know, the site. And
Site-specific
sometimes
tenderness.
one of the very good point is what we do is, if you are not able to see the cervix very well, you just pull out the probe a little bit out,
A little
you know,
bit.
a little bit out, so that the cervix will fall into the focal zone of the transducer.
So
Try
that
to adjust the focal zone of the transducer,
is
and it will be, the image will be very clear. This is also one technique.
This is also
Again, physics is involved.
again physics. One has to be
These
very
are
good.
These are things actually.
So now we can discuss the poll questions, sir.
Yes, sir, madam. We will discuss the poll questions now.
We will discuss the poll question. Now the question number one is a 3-layer endometrium suggests? It suggests proliferative phase. So B is the right answer, and let me explain it to you. Madam had already told us how the basal layer and then the endometrial
Functional layer.
is being laid upon. So the 3-layer happens only in proliferative. In the just after menstruation or during menses, everything is shed off. So we may not see 3 lines. So this is the indicative of 3-layer, means it is proliferative phase. Secretory phase becomes compacted because of the secretions of the endocervical gland, not endometrial gland. The whole it becomes almost compacted because of the mucus and the fluid. So these 3 lines are obliterated in secretory phase. So this is the B is the correct answer. Sir, tell us percentage. Sambit Babu, percentage kete right hai chi?
We don't ask this, sir.
I think he has left. Okay. So the next question is, endometritis can be detected by. So all the points are correct, because all of the above is the right answer, because thickened and irregular endometrium. See, when we look at the endometrium,
Sir, questions not seen.
we look at the regularity, we look at the ecogenicity, we look if there is any fluid in the cavity, and we have to remember that endometrium has to be measured from ecogenic point to the ecogenic point widest. The myometrial zone, the intervening hypoechoic zone, we do not include, because that is a part of myometrium. And also when we are talking about ecogenicity, we are comparing the ecogenicity of the endometrium with the myometrium. So this is the one significant point.
So they are saying poll questions are not visible. Everyone is writing poll questions are not visible.
I think they should go, they should click. They should, if they are doing it from the phone, it will be difficult.
Then sir, third question, sir.
Yeah.
Third question.
And even from phone they can, but I don't know what is the technique. I don't use phone, so I will not know it.
They go to chat box and they will put in the top one. They toss the top one. So discuss the third one. Question number 3.
Sir, question number 3.
Question number 3 is, bright ecogenic strands within endometrial cavity are they suggest the presence of, she had a beautiful slide of synechia, and C is the right answer. You know, in case of fluid, it will be smooth. There will be no, these strands actually, basically these bands are, ecogenic bands are because of adhesions actually. So they will be visible as strands.
And no, sir, also when if we put Doppler, there will be no vascular supply within it.
No vascular flow. And also, see, the best way to look at the synechia is this, as you said, introduce saline in the
SIS, saline infusion sonography.
And this is very, very important. You can actually delineate polyps very well. you can delineate whether it is a myometrial polyp or the endometrial polyp. So saline infusion is one of the best technique.
Best.
You know, right.
Question number
So,
4.
Question number 4, thickened endometrium with loss of endometrial interface. This means that the endometrium has invaded the myometrium. It has gone inside the myometrium, and this is one of the very key features of endometrial carcinoma. The transition line means after the endometrium, it is the hypoechoic myometrial region starts. So any interference, if it is not a very clear zone, if something is invading it, then we know that, okay, this endometrium is really invasive type, or it suggests carcinoma. Commonly seen anechoic avascular structure in the cervix. She showed nice Nabathian follicle, and also that it is anechoic, it is avascular, and she also, Dr. Ranjana also told about how it happens. The squamous epithelium getting over the columnar epithelium and blocking the glands, and therefore there is accumulation of fluid which looks anechoic. So Nabathian cyst is a very, very commonly seen, and they are physiological, we can say. It doesn't have any clinical significance.
Although they may increase in size from 2 millimeter to 20 millimeter also.
Yeah, it
But
can
they may
increase.
be physiological.
And now question number 6 is endometrial polyps have. This was again, she had a beautiful slide of polyp. We will see bright edges, we will see hyperechoic ecotexture, and a single feeding vessel. This feeding vessel, if you put color flow, and always try to remember one of the, again, this is a principle of physics. Your vessel the vessel and the sound wave should be parallel to each other. If they are not parallel, if they are hitting at 90 degree, we will not see any color.
Be able to see.
So this is one of the important point. And sometimes what we do is we put power Doppler, which is angle independent. So that also will help us actually. So endometrial, all of the above is the right answer for question number 6. Now regarding copper T, we had a very good discussion, and a copper T in uterus in correct position, if seen at the uterine cavity near the fundus, is the right answer. So D is the right answer. We had a very beautiful discussion. Also, she had, Dr. Ranjana had nice slides also to depict that. She also mentioned about the distance, which is very, very important and helpful. Now, question number 8, endometrial thickness is measured correctly in. So I just recently, means just few minutes back, I told that it has to be mid-sagittal. How will you know it is mid-sagittal? How at the widest part we have measured. And I have also put in our virtual group one image today. We had a today I was doing a TVS and I just recorded it for our group. And whole endometrial stripe seen from fundus to cervix. And why it is from fundus to cervix is because if we see the whole continuity, then we know that we are exactly in the mid-sagittal position. So all of the above, in case question number 8, D is the right answer. All of the above will be the correct answer. Now, during Doppler scanning of the endometrium, the pulse repetition frequency should be adjusted at
0.3, 0.6.
Yeah, 0.3 to 0.6, because this also one of the slide, it was very, very clearly depicted. So I hope most of you have correctly answered this. So B is the right answer for question number 9. And about color score also, there was a beautiful slide. So B, minimal color. If it is a score 2 means minimal color. Score 4 means
No color is 0.
yeah. And one number color score 1 is 0, means there is no color at all.
No
This
color.
again, please remember this color flow and also the Doppler values, because again, when we are coming to the adnexal region, this will be very useful. We will be again discussing this minimal, this same applies, this score applies for all the Doppler parameters we use for gynec scan. So we will come across this color flow and also this PRF thing again and again during our next discussions. So I hope everybody must have enjoyed, and I specifically enjoyed Dr. Ranjana's talk because she was very elaborate and she prepared so nicely that yeah, I had very little to comment on, you know.
Thank you, sir. Sir, you helped me a lot, sir.
Two experts joined, and we got the best of presentation for our specialists, and I'm very happy for them that they have gained so much, and I too have learned much also from Ranjana. So I hope everybody is happy. Now please wait, because Hasmukh sir has to show us some.
So
Hasmukh sir, your presentations, please.
our next actually presenter again is Dr. Ranjana for next two topics are again, and next time she is speaking again on myometrium. So we will have a lot of discussion about fibroid and how they are to be classified, and what is the position, and Musa again is a terminology we use, and I think we will try to put it beforehand so that you can have the terms and definition you can know.
Thank you, sir. Please include me in that group, sir.
I will do that.
Thank you, sir.
Yes.
Yeah, we have Balram Sahu attending all the session. He again is every day he's reading. He has generated a lot of interest and doing very good work in Titlagarh with me. And I see he has a huge library now, purchasing a lot of new books, and yeah, he has a rich library as such also.
So I'm afraid Hasmukh sir will take your attention off from tricks to ultrasound.
No, that is not the case. That is not the case. I am preparing Dr. Balram Sahu. When I am moving out from Titlagarh, he will take care of my population, actually. Dr. Sahu, are you listening?
You have a selfish interest in training him.
No, that is not selfish. It is not for me, madam. It is for the population. I said about
Yes,
the people.
yes.
People should not suffer. It is not my interest. I am not worried about.
At your age, you should come to a place like Bhubaneswar.
I am not selfish to
so
teach.
that,
If I would have been selfish.
No. It's the wrong word.
Sama ma'am, question dekha galani sheshe jai. Sama ma'am,
Actually, in the interest of the patient.
question dekha galani.
How question to full hai gala, finish hai gala or kon?
ठीक अछि. Hasmukh sir, आपनका presentation को. You should come to Bhubaneswar, and
Yeah, actually, we are
so that
trying
will be
now.
safe.
So
And madam will be in a safer place. That when she had the fracture, that's the time when
that time
everybody
actually
felt acutely that
problem.
you should be at home. You have given enough service to your community over there for long years.
It is so long. It hasn't been very. So I was just trying to see this sliding sign, showing this sliding sign. This is how it has. But trace method is again very good for measurement. And so this is the thing, sliding sign. So once you are pressing, you can see this mucosa and this one, they are moving against each other, telling us that there is no adhesion. In case of deep endometriosis, and many times this is very helpful, because lot of women, they complain of pelvic discomfort, heaviness, and pain. And on seeing just on trans-abdominal, we will see nothing. And this sliding sign will tell us that, okay, there is adhesion, or sometimes we see in between these two places, you know, we can see some hypoechoic region. Ranjana madam, you must have seen a lot of.
Sir, endometriotic nodules we can see over there.
So I think this is one slide I just wanted to tell you, and there is a beautiful slide I
And
was
yes, sir.
download.
And in sir, please, one can see the
Again,
red Indian headdress sign over there. In deep infiltrative endometriosis, you have a red Indian headdress sign because of the dense echogenic fibrosis that occurs in parallel lines. They appear like red Indian headdress.
These
which Mala
lines.
symbol.
right.
Yes,
These
yes,
lines.
Yeah.
These lines.
And these vessels on the these are arcuate.
These are arcuate. We will see it in the
Yes.
next
They look
class.
like a headdress.
These are
It is
arcuate.
particularly painful to the transducer. When you pull the transducer, there is
Right.
probe tenderness, very severe probe
Yeah.
tenderness.
Probe tenderness over there.
Probe tenderness is something also you should learn to appreciate and record.
Right.
So this picture is beautiful. The contraction of the endometrium can be seen even during this year.
Menstruation. During menstruation,
Menstruation,
you can see some blood moving here. You know,
Blood moving
again,
here.
when you are sliding, you will see some movement here in the
You can see
cavity.
the endometrium
Yeah,
and
Yeah.
moving.
Right.
Moving.
This is how this was the slide with
Endometrium,
measurement of this one. This is on 3D. Means, yeah.
Hello.
This is fluid. This is saline infusion. Right? Look at this.
For anemia.
This is the catheter,
Right.
stem of the catheter, and
How
this is this whole is catheter.
Oh, 45 days of Naria.
Right.
That's what I did.
So this again,
Okay. Ha.
hydrographic and with 3D
Yes.
Hydroxyprogesterone message.
menopausal. So these are the calcifications we can see in post-menopausally. We can see
We
some
will study in
calcification.
the next class.
Mockenberg sign, it says. I think that's the end of it. So thank you. It was so nice to, and I think one slide I will put next time. It is a beautiful slide of sliding sign. I could not download it today because it was not possible. Let me see, try tonight, and maybe next time I will show. It's very, very
Thank you,
clearly depicted.
Thank you, sir.
So
Okay.
thank you, madam, and again, miss, it was.
Thank you very, very much.
Yeah.
Ranjana and your guru, Harpuk sir.
Thank you, sir. Thank
All
you,
our
madam.
Is guru for all of us, and it's learning from him, and we are happy that so many specialists are learning also, and our state is richer because of the selfless service of not only Hashmukh sir but for trainers like you who are cheerfully, happily sharing knowledge for the suffering. Really, this is the greatest puja ever one can do for a defeat of the Lord. Very,
Thank you,
very
thank
happy.
you, madam.
I
Thank
think
you,
the
madam.
on-site one is going to be very, very interesting. On-site.
Yes.
Yes, sir.
One side we are all afraid because our depth of knowledge will be. Yes, Sanjay. Yes, yes. You are. I hope you also would have been one of the on-siders because you are quite capable. And so, if you like, you can join our group.
And I think everybody should now start practicing transvaginal. I mean, those who are not doing, let them do it.
That's a good thing I learned from Ranjana.
Thank you.
And for everybody's information,
No, actually,
Professor Sujata Mahanti is 87 and she wants to learn ultrasound. So I said, Madam, I think we should have given her a link actually at the so right from the beginning, because she was wanting to join this group. And I said, Madam, it is only for our working specialists. I really feel very sorry that I didn't give her the link. Now I think we should start the private practitioners training group, Ranjana, so that she can join. She at this age, she's very keen to learn. She's my professional ideal. She keeps learning at every age. Learned laparoscopy. She learned the ultrasound, the URPSS, the pelvic organ prolapse, and the things she learned. So really, she just 2-3 days back on Guru Purnima day. Guru Purnima, she is my guru. She came up to me, my house, and she said, "I want to learn sonography. I bought the machine, but I couldn't do it. So I said, Madam, we'll see that you definitely learn." So Hasmukh sir, it's your duty to teach Sujata Madam. You were there during her wedding.
Sure. I will do that.
It's your duty. We should come down to her and let her hold the transducer. We'll be with her. And, really, I was so moved.
Actually, Madam,
Purnima day, my guru, she wanted to see me after TKR, and that happened to be on Guru Purnima day. And then she told me I wanted to learn ultrasound or opsos rahegala. But Madam, I'll see that you since you have the wealth of knowledge and experience, you'll definitely learn very quickly.
She will learn, yeah.
So it's a duty now to go down to her and see that.
Actually, ମୁଁ ଦେଖିଛି ଆପଣ ଦେଖିବେ ମାନେ ଏଇ जो basic training ଯେତେବେଳେ ଚେନ୍ନାଇ ରେ ବି ହଉଥିଲା ବହୁତ older people were there. Dr. Ranjana is a witness to that. Many older
many fellows were there.
because they are doing ultrasound for a long time, but they don't know the basic. So we also have a lot of people who really, if they have not attended a basic course or they have not known the basic foundation, then they will not be able to do in a very correct fashion, because all the basic thing means brick by brick.
Madam, let us start straight away and tell.
I'm not able to hear you.
Tell us what is your convenient time and which time also. From 8 to 9 will be convenient for practitioners.
For me, any time is
half an
convenient.
hour if we can give.
8 to 9.
Straight away because of the
8 to 9 we can do anything, no problem.
straight away. Yes. Okay.
How?
Then shall we?
Madam, thank you, Namaskar, madam. Thank you.
Especially those who are staying till the end, 35 people are still there. So thank you very much. Balaram is still there. Sanjay Rai is still there. Sanjay, our private practitioners ମାନଙ୍କ ପାଇଁ କରିବା.
संजय तो कैपिटल रे अछि मैडम. संजय कैपिटल रे अछि.
Sanjay will be benefited because I will be with him, often. Sanjay, I often will go to him actually. Sir, I once went most also.
Welcome, sir, most welcome.
Okay, Sambit, shall we close the meeting?
I think it is okay. Good time to.
Thank you, madam. Thank you.
Namaskar.
Yes,
Namaste,
thank you,
sir.
Neha.
Namaste, everyone. Sir.
I'm so happy you joined this. So, Sambit, shall we close the meeting? Sambit is there. Okay.
ये अच्छी ये जींस खाए के ताकि Hello.